Welcome. In this talk, we'll explore the fascinating field of neuromodulation, the science of influencing brain function to promote healing, performance, and mental well-being. Modern neuroscience is giving us tools that allow the brain to be seen not as a fixed organ, but as a dynamic network capable of remarkable things. Through approaches such as neurofeedback, transcranial direct current stimulation, and hyperbaric oxygen, we can now work with the brain's own plasticity to restore balance, improve mood and focus, and optimize mental health. My name is Dr. Frans J, and I lead the Department of Baromedicine at King Ahmad American Mission Hospital in Bahrain, where we integrate neurophysiology, hyperbaric medicine, and personalized care to help individuals recover, adapt, and thrive. Let's begin by looking at how these technologies converge to form a new, integrated model of mental health optimization. So to start, what is modulation as in neuromodulation? It is the intentional adjustment of neural activity to change how the nervous system functions, aiming for therapeutic, restorative, or performance-enhancing effects. In this talk, I would like to explain where this fits into our aviation and diving medical practice from the perspective of its relevance, that is, why do we do it, and resources, how do we do it. This slide represents a pivotal moment in aviation psychiatry, when on the 24th of March 2015, Germanwings Flight 9525 was deliberately crashed by co-pilot Andreas Lubitz, killing all 150 people on board. Lubitz, suffering from severe depression, locked the cabin out of the cockpit and at a speed of 700 km per hour flew the Airbus A320 directly into the French Alps. This tragedy prompted global reforms in pilot mental health screening and cockpit access protocols. Similar events include Egypt Air 990 in 99, Silk Air 185 in 97, and Japan Airlines 350 in 82, each involving pilots struggling with depression or mental illness. These tragedies underscore why mental health support, early intervention, and non-punitive reporting systems are essential for aviation safety. In most professions, we would advise people with mental health challenges to rest, slow down, and avoid stress. In aviation, that advice is impossible to follow. Pilots face fatigue, isolation, unpredictable stresses, and constant high-stake decisions, conditions that can quietly erode resilience if not addressed proactively. In the wake of the Germanwings disaster, a 2016 Harvard study showed that more than 1/8 of pilots experience clinical depression, and around 4% report suicidal thoughts. The FAA's toxicology data from recent incidents reveal that alcohol and drugs remain a significant concern and are often linked to untreated psychological stress and near-miss accidents. Peer support programs are now mandated worldwide to address this. But in the Middle East, we face unique barriers. There's denial, stigma, and lack of structured rehabilitation, meaning many pilots still suffer in silence rather than seek help. This slide explains why psychoactive medications are often not an option for pilots, divers, or anyone operating heavy machinery. Even small doses can impair judgment, slow reaction times, cause drowsiness or disorientation, all catastrophic in safety-critical environments. These drugs may also destabilize mood, blur vision, or trigger dependency and withdrawal symptoms. But beyond the clinical effects, most are outright disqualifying under aviation and diving regulations. So while medication may help on the ground, in aviation, it can compromise performance safety and licensing, leaving few safe pharmacological options. Dr. Daniel Amen is a renowned American psychiatrist, brain imaging expert, and founder of the Amen Clinics. His work emphasizes that mental health is fundamentally brain health, a shift that transforms how we understand and treat psychological conditions. To echo his words, reframing the discussion from mental health to brain health changes everything. People begin to see their problems as medical, not moral. It decreases shame and guilt and increases forgiveness and compassion from their families. This perspective invites empathy instead of judgment and opens the door for science-based restorative care. The key takeaway is simple. Supporting mental health, or rather brain health, in aviation, diving, and other high-risk professions is not a luxury. It is a regulatory, ethical, and performance imperative. When lives depend on clarity, focus, and resilience, caring for the brain becomes as essential as maintaining the aircraft itself. King Ahmad American Mission Hospital is committed to advancing mental and brain health in high-performance and safety-critical professions. Our baromedicine, aviation, and neurophysiology units offer evidence-based screening, peer support, and neurocognitive rehabilitation resources, integrating medical science, ethics, and human care to promote resilience and safety in aviation and diving medicine. So, welcome to the Aviation Medical and Baromedical Wound Care Department at King Ahmad American Mission Hospital in Ali, a center where science, safety, and compassion meet. Our aviation clinic and baromedicine unit operate side by side, reflecting a unique, integrated model that serves pilots, divers, and patients requiring advanced hyperbaric and wound care. Here, medical precision, ethical excellence, and human empathy work together to enhance performance, recovery, and resilience. Our approach combines 4 synergistic therapies: neurofeedback, transcranial direct current stimulation or tDCS, hyperbaric oxygen therapy or HBOT, and KB220, a neuronutrient formulation. Together, these modalities form a restorative framework for mental resilience, performance optimization, and recovery. This slide clarifies the scientific and regulatory context for the modalities we use. Using the Oxford Centre CEBM classification systems, these modalities all have level 1 or 2 evidence in support of their use. Under regulatory status, the red asterisk indicates modalities where indications align with recognized approvals. Neurofeedback is cleared by the US Food and Drug Administration as a Class II medical device, exempt from additional pre-market notification under the 510(k) pathway, and CE marked in Europe for biofeedback training. Transcranial direct current stimulation is classified by the FDA as an investigational device under an investigational device exemption and granted breakthrough device status, meaning it allows early evidence of significant clinical benefit for serious conditions where no approved alternatives exist. It is also CE marked under the European Union Medical Device Regulation for specific therapeutic and research purposes. Hyperbaric oxygen therapy is fully cleared and CE marked for approved medical conditions, including carbon monoxide poisoning, decompression sickness, chronic non-healing wounds, and radiation injury, etc. Lastly, KB220, now marketed under the name Synap, is registered as a dietary or food supplement under both the FDA and European Food Safety Authority. It is not a medication, but is used within its recognized nutritional and neurochemical support frameworks. The first modality I'd like to introduce is neurofeedback. Neurofeedback is essentially brain training through real-time EEG feedback. It's completely non-invasive and teaches the brain to regulate its own activity using principles of operant conditioning, meaning small rewards for desired brainwave patterns and inhibition for those that are less efficient. It is not something done to you, but rather for you and with you, a collaborative process between the clinician, the technology, and the patient. Over 15 to 35 sessions provides enduring enhancement of cognitive performance, emotional regulation, and mental stability, skills essential for aviation, diving, and high-performance medicine. This diagram illustrates how neurofeedback works. Sensors on the scalp measure brainwave activity, which is sent through an amplifier and displayed on a computer. The neurofeedback practitioner monitors these signals and adjusts the training frequencies according to the individual's goals and symptoms. Meanwhile, the client receives real-time feedback through a video game or movie. The brain is rewarded when it functions in a desired pattern and inhibited when it drifts off track. Over time, the brain learns from this process, just like learning to balance on a bicycle. It develops the ability to self-regulate. In short, neurofeedback teaches the brain to recognize its own rhythms and to optimize performance naturally, without medication. This table summarizes the key areas where neurofeedback has demonstrated benefit in mental health. For ADHD, the evidence is strongest, with multiple randomized controlled trials showing improvements in attention and reduced impulsivity at Oxford CEBM Level 1B. For insomnia and anxiety disorders, all noted by red asterisks, neurofeedback has also shown efficacy in improving sleep efficiency and reducing anxiety symptoms. In depression and PTSD, the evidence is promising, showing better mood regulation and emotional control, particularly in trauma-related dysregulation. Applications in substance abuse disorders and autism spectrum disorders are still emerging, with strong evidence for supporting self-regulation and social functioning. Overall, the pattern is clear. Neurofeedback consistently enhances cognitive control, emotional regulation, and resilience across diverse mental health conditions, with evidence quality ranging from moderate to strong. This case highlights the transformation that can occur with structured neurofeedback training. The subject was a 41-year-old psychotherapist who had already received multiple therapies from CBT to hypnotherapy, but continued to struggle with emotional dysregulation, sensory hypersensitivity, mental fatigue, and social withdrawal. After completing neurofeedback, she reported a marked reduction in anxiety, restored composure, and greater emotional resilience. Her thinking became clearer and more creative, with improved mood regulation and focus. Perhaps most meaningfully, she described being able to experience emotions deeply again, without fear or shutdown, and her speech became calmer and more deliberate, reflecting inner stability. This illustrates neurofeedback's potential to restore balance, confidence, and authentic emotional presence, even in individuals already experienced in psychotherapy. Now, it's one thing to say it, it's another to quantify it. Can we do so? And the answer is yes. This diagram shows a standard 1020 EEG system. In our standard measurement configuration, known as a montage, signals are recorded from the front, that is FP1 and FP2, to the back of the head, O1-O2, in a zigzag sequence, encompassing frontal, central, temporal, parietal, and occipital regions. So the channels you see on this EEG follow the overlay sequence from front to back. Before neurofeedback on the 13th of March, the EEG shows diffuse, excessive theta, and poorly defined alpha activity, which is typical of cortical underregulation. Waves appear irregular, reflecting variable arousal and reduced focus. After 30 sessions, the EEG becomes more stable and organized. Theta decreases, alpha strengthens, and rhythms show clearer symmetry, signs of improved cortical control and focus. For now, we are looking at the appearance or quality only, and the changes are, qualitatively, that the brain now shows a reduction of theta, better arousal regulation, an increase in alpha, improved calm focus, variability decreased with more efficient neural communication, organization improved with evidence of neuroplastic changes and a training effect. This mirrors the changes in symptoms reported by the subject. Neurofeedback is not new. It has been studied for more than 6 decades, with published literature documenting its applications across clinical, cognitive, and performance domains. Yet for many clinicians, the challenge remains in understanding how to interpret and apply the evidence in practice. For those who'd like to explore this further, here are 3 accessible resources. In The Body Keeps the Score by Bessel van der Kolk, Chapter 19 offers one of the clearest summaries on neurofeedback in trauma recovery. A Symphony in the Brain by Jim Robbins gives a fascinating, although slightly dated, history on how the field developed and its applications. Restoring the Brain is for clinicians, edited by Hanno Kirk, and provides detailed case-based applications across psychiatric and neurological conditions. Let's move on to transcranial direct current stimulation, or tDCS. tDCS delivers a very low electrical current through the scalp, usually targeting the left prefrontal cortex at site F3. It gently modulates brain activity to improve mood, cognition, and emotional regulation. It is painless, safe, and complements neurofeedback in optimizing mental performance and resilience. tDCS typically applies about 2 milliamps of current for 20 to 30 minutes. This slightly polarizes the cortex, with the anode increasing cortical excitability and the cathode reducing it. The patient usually feels a mild and tolerable tingling sensation over the electrodes. With repeated sessions, typically around 10 or more, the brain undergoes neuroplastic changes that lead to lasting effects on regulation, focus, and emotional stability. The main stimulation site, in most cases, is the left dorsolateral prefrontal cortex, which is known for executive function, emotional control, and goal-directed behavior. It is linked to so-called approach behavior, motivation, planning, and maintaining positive affect, which is why it's a common target for tDCS, neurofeedback, and magnetic brain stimulation. It is specifically relevant in treating depression, ADHD, fatigue, and cognitive dysfunction. The evidence for tDCS continues to strengthen. Meta-analyses and randomized trials show benefits across multiple conditions. In depression, level 1B with improved mood and affect regulation. In chronic pain, level 1B to 2A modulation of pain pathways. In cognition and fatigue, level 2A to 3B enhancing working memory and mental clarity. Anxiety level 2B reduction in physiological and emotional tension. And overall, tDCS demonstrates consistent, moderate to strong evidence for improving prefrontal regulation and resilience. Next, we turn to hyperbaric oxygen therapy, or HBOT. HBOT involves breathing 100% oxygen at pressures ranging from 1.5 to 3 times atmospheric pressure. This increases oxygen delivery 10 to 15-fold, allowing the body and especially the brain to meet full metabolic demands. By raising plasma oxygen levels, HBOT supports repair, neuroplasticity, and recovery in both injury and stress-related conditions. Although the brain makes up only 2% of body mass, it receives about 15% of blood flow and consumes roughly 20% of the body's oxygen. To meet its high metabolic demand, the brain directs oxygen and blood regionally through neurovascular coupling, also known as brain activity-mediated hyperperfusion. Under stress or overload, this process prioritizes survival-related circuits, often at the expense of higher cognitive and emotional functions. This selective neurovascular coupling also means that during overload, regions responsible for speech, reflection, and executive control receive less blood flow in relative cerebral hypoperfusion. HBOT bypasses this limitation by saturating plasma oxygen and ensuring that the brain no longer has to choose which regions to support. This enables balanced neuronal activation and facilitates both emotional and cognitive reprocessing, which is why HBOT is effective in conditions such as refractory PTSD and fibromyalgia. Although many neurological and psychiatric indications are still considered off-label, the evidence base for HBOT has expanded rapidly. Levels 1A and 2A studies now support its role in improving cognition, mood, and neuroplasticity across multiple conditions, from post-COVID fatigue to mild TBI, PTSD, fibromyalgia, and early cognitive decline. Although HBOT and neurofeedback have each been used successfully in treating a wide range of conditions, there are only 2 published case studies that have explored their combination, and both apply the modalities sequentially rather than simultaneously. While the reported outcomes were positive, they involved nearly 200 neurofeedback and 300 hyperbaric sessions per case, which is clearly not a feasible regimen. This presentation introduces a novel approach pioneered by our department, the simultaneous application of hyperbaric oxygen therapy and neurofeedback. It represents an intuitively strategic, synergistic, evidence-based model that integrates physiological repair and neurocognitive recovery within a single, efficient therapeutic framework. Here's the team in our department that inaugurated this process on the 9th of August 2024. This is a video of our first patient receiving HBOT. After applying the electrodes to the scalp, the patient is transferred to the inside of the hyperbaric chamber and the pressure is gradually increased to 2 atmospheres absolute. At that point, the patient starts the neurofeedback and the television screen responds to the brain signals by either darkening or brightening in response to the patient's response to the parameters that are set. These interventions are particularly suited for conditions involving neuroinflammation, dysregulation, or impaired neurovascular function, such as with long COVID, mild TBI and stroke, PTSD, and fibromyalgia. Together they help the brain regain function and better regulation. Lastly, KB220. This is a patented neuroadaptogen developed by research psychiatrist Professor Kenneth Blum. It's designed to restore dopamine balance and support the brain's reward circuitry, enhancing focus, mood stability, and recovery across multiple neuropsychological conditions. I have no commercial or financial interest in KB220 or any related products. This presentation shares independent, evidence-based findings to advance clinical understanding and best practices in brain health interventions. Research on KB220 spans global collaborations addressing addiction, trauma, and cognitive performance. Recent studies, including our own, demonstrates measurable improvements in neural efficiency and cognitive function following KB220 administration. KB220 functions as a neuronutrient adaptogen. It helps normalize the brain's chemical ecosystem, particularly dopamine, serotonin, GABA, and endorphins, thereby supporting both emotional and cognitive function and recovery. KB220 enhances dopaminergic signaling and restores balance between excitatory and inhibitory systems. The result is steadier mood, sharper focus, and greater motivation. Importantly, it is not a controlled substance, and it is not a stimulant. It is a regulator. By recalibrating the brain's main transmitter systems, dopamine for drive, serotonin for mood, GABA for calm, and endorphins for a sense of well-being, KB220 promotes a better synchronized reward cascade and sustained mental energy. The GARS, or Genetic Addiction Risk Score, is part of the KB220 research landscape. GARS identifies genetic vulnerabilities in dopamine and serotonin pathways. Those with higher reward deficiency scores may particularly benefit from KB220's balancing effects. Clinical and imaging data show that KB220 reduces cravings, eases withdrawal, and increases activation in reward circuits. It supports recovery by restoring healthy neurochemical tone. Evidence for KB220 spans a wide range of neurocognitive and behavioral conditions. In addiction recovery, it reduces cravings and enhances treatment compliance. In ADHD, it helps normalize dopamine homeostasis, improving focus and reducing hyperactivity. For PTSD, it calms intrusive thoughts through stabilization of the brain's reward cascade. Studies also show improved working memory, mood regulation, and connectivity in resting state networks. Across conditions, KB220 enhances dopaminergic tone. It stabilizes neuronal communication and supports relapse prevention through lasting reward system balance. Among the brain-normalizing supplements, KB220 stands out for its broad mechanistic scope and research depth. It remains one of the most extensively studied neuroceuticals in its class. This case describes a 29-year-old male with multiple neuropsychiatric diagnoses, including ADHD, autism, and depression. And he was struggling with poor focus, impulsivity, and emotional dysregulation. A single dose of KB220 was introduced while under EEG surveillance to record quantifiable neurophysiological findings. EEG recordings were taken immediately before and 1 hour after the administration of KB220. The subject remained seated with the electrodes in place, ensuring identical recording conditions and eliminating setup-related variability. This shows the so-called power spectral density curve, which represents the distribution of brainwave energy across frequency bands. Each peak corresponds to a dominant rhythm within the delta, theta, alpha, beta, and high beta range, which reflects different functional states from deep sleep to focused attention. The height of each peak indicates the relative power within the frequency band. By tracking shifts, we can objectively quantify changes in arousal, relaxation, and cortical activation. Here we see again the International 1020 electrode placement system used to determine the spectral signature of each underlying cortical region, for example, over the prefrontal cortex areas. This mapping enables us to assess measurable or quantifiable QEEG changes that occur following KB220 administration in this case, rather than just focusing solely on morphological or qualitative changes. In other words, we calculate the microvolts of respective frequency ranges rather than just examining the shape of the EEG waves. This slide represents the baseline power spectra recorded before KB220 administration. You may notice the multiple regions, especially in the frontal and central areas, with elevated low-frequency power, mainly theta and slow beta, indicating cortical underactivation and inefficiency. These slow rhythms often reflect fatigue, distraction, or emotional overprocessing. 1 hour after KB220, we see a clear normalization of spectral power. The dominant peaks shift towards the alpha range, with reduction in slow wave amplitude across frontal and central regions. The pattern is consistent with enhanced neural efficiency, less noise, and more synchronized activity, and it supports the proposed dopaminergic and neuroenergetic balancing effects of KB220. This table summarizes the numerical spectral data before and after KB220. The red boxes highlight frequency bands where there were significant shifts in peak electrical power. In simple terms, the power of the slow waves decreased and the dominant awake frequency became synchronized. In essence, this indicates a shift from diffuse cortical idling to organized, wakeful calm, an electrophysiological signature of improved reward and attentional regulation. Our objective is to align electrophysiological findings with clinical presentation, ensuring that interventions are not only symptom-based but also precisely guided by measurable brain function. Our approach remains function-based, not pharmaceutical, and fully compatible with aviation safety standards and patient preferences. The impact of this model is profound. It offers hope, empowers patients, and promotes active, sustainable recovery. We advocate for broader system integration, creating dedicated practice units for brain health, strengthening substance abuse support, advancing occupational mental health programs, and expanding research and education in this field. Ultimately, integrated neuromodulation means optimized resilience, translating scientific insights into practical implementation for real-world mental health transformation. To find us, just search KHAMH and aviation on Google. It will take you to our website. There you will find baromedicine services with options ranging from aviation and diving medicals to hyperbaric oxygen neurofeedback, transcranial direct current stimulation, and QEEG assessments. If there are any questions, please feel free to post them in the chat below this video. Thank you for watching this presentation.